warahmatullahi wabarakatuh. Good evening, everyone. My name is Suhail Abdullah Alrukn. I'm a consultant neurologist and the president of MENA STROKE Organization. Tonight is the last webinar for this year, for 2022, where we had a wonderful year with more than this number 12 for this year, and this number 22 for the last since we started these type of webinars and education. Today we will have a nice webinar for the next 90 minutes with a distinguished speakers. I would like to introduce my co-chair today, Dr. Athari Salmeen. He is a senior neurologist and consultant stroke specialist at hospital in Kuwait. Dr. Athari is trained and finished her residency program and also a stroke fellowship from Vancouver, Canada. Currently, Dr. Athari is the chairman of the stroke chapter and a member of the Kuwaiti stroke, member of Kuwaiti Neurology Society. And I'm giving the mic to Dr. Athari to introduce our two speakers today.
Thank you very much, Dr. Suhail. Hello, everyone. Our first speaker is Professor Carlos Molina. He's a professor of neurology at Autoimmune University of Barcelona and head of neurology section and stroke unit at Vall Hospital. Hopefully pronounced it correctly. He's also the chair of the Vall Stroke Center and the co-founder of Nora Health. His area of specialization includes, but not limited to, neurology, stroke, digital health, and high-value care and healthcare management. Moreover, Professor Carlos Molina has conducted several multi-center clinical trials and prospective registries for acute stroke. He has more than 580 papers in peer-reviewed journals, mainly in the field of non-invasive evaluation of deep perfusion in acute stroke. Today, he will talk to us about controversies in acute stroke management. The mic is yours, Dr. Molina.
So thank you very much for the introduction. For the introduction. So I'm going to share my slides. Just let me know if you see my slides. I think so.
Yes. Yes, Professor, we can see the slides.
Oh, yes. I need to remove this. Just a second. Okay. Yeah. So, so I can get back. So thank you very much. First of all, I would like to thank the organizers for the kind invitation to participate in this educational program. This is the second webinar that I participated so far this year, and I'm really privileged to be part of it and share with all of you some ideas on what I think, and many of my colleagues think there are controversies in acute stroke management. So you can see here, this is my disclosures. So there are three main controversies in stroke management nowadays. So one of the is TNK is ready to replace TPA in acute stroke. The second one is whether reperfusion therapy is indicated for patients with minor strokes and TIA. And the third one is if we are willing to skip TPA in candidates for mechanical thrombectomy. So, as all of you know, TNK is a genetically modified form of TPA that has a specific properties. So 3 points of the TNK molecules has been changed to produce a very specific molecule, very specific for fibrin, highly specific for fibrin, more resistant to be digested by plasminogen. It confers some logistic advantage, mainly that is used as a single bolus administration, so it's not continuous infusion like TPA. So in animal models, it has been demonstrated to be much more effective, up to 1,000 times more effective in clot lysis compared to TPA. However, in clinical trials in myocardial infarction confers similar advantages, just the logistic advantage, in some cases, higher rates of recanalization. In stroke patients, so several trials have demonstrated in a retrospective analysis, as you can see in this meta-analysis, showing that overall TNK is not inferior compared to the native IV TPA. However, all these trials were not designed to demonstrate non-inferiority. Using the two doses of 0.25 and 0.4 milligrams per kilogram of TNK as a single bolus compared to TPA. So in this study, this pool analysis showed no difference with TPA and similar safety. This is the safety profile of TNK compared to TPA. However, again, this study were not designed to demonstrate non-inferiority in safety and efficacy. That's why the recommendation for the European stroke guidelines is for those patients who are not candidates for mechanical thrombectomy. It means in unselected stroke patients, still TPA is the standard of care. So the evidence is low because it's based on retrospective studies. However, recently, in July this month has been published in Lancet Neurology the results of a Canadian trial showing clearly, and in this case they designed the trial for non-inferiority, that TNK is not inferior to the dose of 0.25 milligrams per kilogram compared to TPA. So as you can see in this slide, there were no major difference in safety and also in efficacy. So probably we need more information about how to use TNK of the next month. So more trials are ongoing and will give us more information about that. A different situation represents those patients who are candidates for mechanical thrombectomy. So small trials conducted mainly in Australia showing that TNK may increase the rate of pre-interventional recanalization, means before diagnostic angiography, before thrombectomy, so and higher rates of good outcomes. As you can see in this slide, so the rate of excellent outcome means modified ranking scale 0 to 1 was the double in those patients with TNK previous to mechanical thrombectomy. But now what we have are clinical trials trying to demonstrate or to expand the scenario of use of TNK, but maybe in the future it will replace the TPA, but not now. We need to clearly define in the window for TPA, what is the dose, what is the more proper dose of TNK to be used in unselected stroke patients, a large data sets in different scenarios around the world. So these are the list of clinical trials, currently underway, the ATIS-2, the TASTE trial using advanced imaging. This trial is about to be finished in Australia, in Asia, and some European countries, using the 6-hour window using advanced imaging for patient selection. The TEMPO-2 expand the window till 12 hours, but for minor strokes and TIA with persistent occlusion of perfusion deficit on CT perfusion, and the TNCAT trial that we are conducted this pragmatic trial in Catalonia in the drip and ship scenario. This slide shows the different studies on comparing TPA and TNK. Just to know that in NORTES-2 demonstrated was stopped due to safety concerns. The dose of 0.4 milligrams per kilogram of TNK was associated with an increased risk of intracranial hemorrhage, and this was the reason why this trial was stopped. It seems that the dose is going to be 0.26, and the timeless trial is still ongoing in the extended time window using advanced imaging for patient selection. So in the window for 4.5 to 24 hours. So there are also biosimilars of TNK that are being produced in different countries, in China and in India, and in particular due to this shortage of TNK. So we are suffering now in Europe and in other countries a shortage of TNK production, and that's why these biosimilars are being tested in these different trials. The T-Flavor in Japan, TRACE 2 and 3 in China, Chablis also in China, at the reopen in India. However, as you can see in this slide, there are differences between the metallized, the TNK with the biosimilars in terms of the rate of clot lysis is not exactly the same. So we'll see the results of clinical trials in terms of actual recanalization and the impact on clinical outcome. So the second topic is thrombolysis with in patients with TIA and minor stroke. So some of you know, half of our stroke patients are minor at the initial, at least the presentation. It means an NA stroke scale score of 5. Some of them are not clearly demonstrated on clinical grounds, so maybe mild facial drop. And at 1/3 of these minor strokes are disabled at 3 months. So in disabling stroke patients, it has been demonstrated that TPA works. TPA was effective and was associated with good clinical outcomes. So the evidence behind that is very strong, and the level of recommendation is also high. So the recommendation of the guidelines is to treat patients with disabling stroke, even if they have a minor neurological deficit. So what to do with those patients with non-disabling stroke? So the definition of disabling or non-disabling is based on the treating physician, of course. But the general definition is that any neurological symptom that is affect the quality of life, daily living activities for the patient. So using this definition, so for no disabling stroke, the PRINCE trial demonstrated that it was no effect of TPA in these patients, and there was a high rate of symptomatic intracranial hemorrhage. 3% for those mild stroke is really high. So that's why the trial was stopped, and the recommendations of the European guidelines and other guidelines also reflect this lack of efficacy in this non-disabling stroke population. So the recommendation is to not treat patients with non-disabling stroke with TPA. However, the definition of disabling and not disabling is much more complex, and the time constraint to thrombolysis, so a very short and narrow time window, is difficult to the decision making. And to define minor stroke, we have to take into account that there are some non-eloquent areas that can provide larger infarctions, or difficult to assess the baseline situation of the patient, of the desires of the patient, the family, and also the NIH is a poor scale to capture the entire level of disability. At the long term, there are aspects of the clinical disability that are not captured by the modified ranking scale score, like fatigue, selective disturbance, visual problems, and cognitive difficulties. So recently, our group demonstrated that in patients with TIA and minor stroke, with and without recanalization therapies. So there are some of these patients are disabling despite having a modified ranking scale score 0 to 1. Despite having an excellent outcome, they are depressed in up to 26% of patients, and half of them have signs of dementia at 1 year of follow-up. So this is important and relevant to have this global vision of clinical stroke disability at long term, even in minor strokes and TIA. So what is the situation in the world? So some centers treat no patients, no minor stroke or TIA patients, or just those clearly disabled. Some of them use advanced imaging to better refine the identification of these patients based on the presence of occlusion or perfusion deficit, and some of them they treat all comers. So what we need to take into account is the rate of clinical deterioration in mild stroke. So in this slide, you can see the factors associated with clinical deterioration. So old age, diabetes, the presence of high glucose levels, of changes in blood pressure. But by large, the most important factor associated with clinical deterioration is the presence of a severe stenosis or occlusion. So that's why in a panel of experts of the European Stroke Organization, in the guideline committee, the experts, 6 of 8, voted in favor of treat patients with non-disabling stroke in the window of 4.5 hours with TPA if they have a large vessel occlusion. It seems clear because you don't have the time to react rapidly if the patient experiences clinical deterioration. So if you have a patient with minor stroke and a large vessel occlusion, so there's an indication of TPA despite not having non-disabling symptoms. So what about endovascular treatment? If you can treat with TPA, why not endovascular treatment? So This is a matter of extensive research. So some authors demonstrated that in patients with proximal occlusion, so the rate of recanalization seems to be higher, and of course, and the outcome was better. However, there was an increased risk of intracranial hemorrhage in this population. Also in registries like this Florida, Puerto Rico, large registry in minor stroke patients who receive 11%, like more than 400 patients received endovascular treatment. There was an unacceptable high rate of symptomatic intracranial hemorrhage, high rate of mortality, and some of them were discharged not at home. At 25% were discharged to a home facility. So anyway, so there are currently randomized trials trying to compare the benefit of treating patients with distal occlusions or non-disabling strokes. So like the distal trial, ESCAPE-MIBO, and also the MOSTED trial that are ongoing. The third topic, what is the rationale behind skipping IV-TPA for thrombolysis? If you are tempted to, okay, and we are in front of the angio suite, we have the patient right away, just in front of the angio suite, why not treating the patient with TPA? It seems very straightforward. So actually, there are some people, some neurologists and interventionists, that they consider that we need to skip TPA because the low recanalization rate, especially in patients with large vessel occlusions, just 10 to 30%. The increased risk of intracranial hemorrhage with the combination. If you skip TPA, you may probably lower the rates of symptomatic intracranial hemorrhage, or the risk of thrombus migration because the clot is more fragile after thrombectomy, and you can promote distal embolization, or increased risk of the cost of adding TPA to the whole procedure, or delay on the growing puncture, or by looking for the pump for TPA, and not only the bolus, but also the pump and the infusion. It may delay the process. And also for some patients, it can be problematic to put TPA because they have tandem occlusions, for instance, you have to place an stent in. So dual antiplatelet therapy to be added on board. So the risk of hemorrhage will be high in those patients who have also TPA on board. So those who are in favor to bridging, for the bridging approach, so support the idea that thrombolysis may help increase recanalization rates to adding to mechanical thrombectomy. And even you can have some proportion of patients that have pre-interventional recanalization, means recanalization before mechanical thrombectomy. Also, some of them defend that, okay, so if you have this developed process of care in the stroke care pathway, so there is no delay to start the treatment, since you do the process in parallel. And also thrombolysis is the standard of care for TPA, and the evidence of mechanical thrombectomy in TPA candidates has been built on top of TPA. So this slide shows the clinical trials, randomized clinical trials of skipping TPA, direct thrombectomy, versus TPA plus mechanical thrombectomy, bridging. As you can see, the numbers are quite different in terms of patients recruited in those trials. Two of them were performed in China, the direct MT and DEPT, and the other, the Mr. Clean No IV in Belgium, the Netherlands, and France, and the SKIP in Japan. You can see very similar populations overall. But the main difference was the definition of non-inferiority. Non-inferiority means it's the same to send the patient directly to the angio suite, skipping TPA, or putting TPA plus mechanical thrombectomy. Actually, the two trials that show non-inferiority were the two Chinese trials, the direct MT and the DEPT, the direct MT. So this lower confidence interval, they achieved the goal of non-inferiority. However, they use a very generous definition of non-inferiority, and the DEPT, they show a marked difference, risk reduction, and the effect of mechanical thrombectomy over TPA plus mechanical thrombectomy. However, it's important to remark the door-to-needle time. So the performance of TPA in these centers participated in direct MT, and that was very poor, with door-to-needle times very long, almost around 1 hour, compared to the Mr. Clean trial was 30 minutes. So the trial also in Japan were 50 minutes. So this tells you a lot of the performance. The performance of TPA and the workflow for TPA has to be less than 30 minutes to, or no, like 60 minutes to have better results. So more than transfer the patient directly to the angiosuite, we need to improve our workflows. This is the main message. So the other two recently published trials, the SWIFT Direct and also the SAFE Direct Safe, they demonstrated that there's non-inferiority. They didn't achieve this goal to demonstrate non-inferiority of mechanical thrombectomy plus TPA against TPA alone, mechanical thrombectomy alone. Actually, the group of who received mechanical thrombectomy in the SWIFT Direct, they have a higher rates of intracranial hemorrhage. So this is the summary. You can see non-inferiority was demonstrated just in 2 trials, Direct MT and DEB, both of them with very long time for door-to-needle time, very poor door-to-needle times, and in the SAFE Direct, there was increased risk of mechanical thrombectomy alone. So the main message is still bridging is the option. If you have no other option, that just if the patient has fulfilled all the criteria for TPA, so he has to receive TPA before mechanical thrombectomy. So in conclusion, so IV thrombolysis is still the standard of care versus TMK. There are trials and also studies around the world trying to compare the logistic advantage. They are trying to take profit of the logistic advantage of TMK, but we are suffering as a shortage scenario. So bringing TPA and the vascular treatment may be an option and may improve outcome, but this is based on the very small sample of patients, no more than 200 patients. More trials will come up and give us more evidence, more solid and robust evidence about the effect of the combination of TNK plus mechanical thrombectomy. On the other hand, disabling minor stroke are candidates for TPA for sure. And if the patient has a large vessel occlusion, so with a disabling stroke, mechanical thrombectomy is under investigation currently in different clinical trials. For non-disabling stroke with large vessel occlusion, TPA is recommended by the European guidelines. However, if no large vessel occlusion, there is no evidence supporting the use of TPA in non-disabling stroke. Again, we need to refine the definition of disabling and not disabling in a better way for future studies. Today, there is no reason to skip TPA before mechanical thrombectomy or TNK in the future, and except some situations, special situations. For example, if we have a patient just in front of the angio suite and the door-to-needle time cannot be prolonged more, or the patient has really this kind of not formal contraindication, but they have all patients with a high risk of hemorrhage, but not formal contraindication for TPA, or patients with a past history of intracranial hemorrhage, for instance, and the angio suite is available. Some of these scenarios, we can skip TPA of patient with a tandem occlusion. And we really think that the best we can do for the patients is put an stent in and do antiplatelet therapy. Is our mind after reperfusion. So in that case, probably there are some exceptions that we can skip TPA. But as a general rule, so TPA shouldn't be skipped for these patients. And there are trials using also the combination of TPA plus mechanical thrombectomy, using TNK, using the single bolus administration, this advantage, logistic advantage of TNK. Actually, one of the trials are the Techno trial using TNK for rescue distal emboli. This is a different approach, like the choice trial that you perform mechanical thrombectomy. If the mechanical thrombectomy is unsuccessful in terms of complete recanalization, which you can add thrombolytics. TPA is what we demonstrated here in Catalonia in the choice trial, but also we can use TNK for this trial. So more trials will come and will improve the quality of the evidence for reperfusion therapies in this scenario. And that's all. And thank you very much for your attention. I'll be more than happy to respond to questions.
Thank you so much, Dr. Molina. I think you summarized it quite nicely. The main controversies that we have with the actual evidence-based. I believe Dr. Suhail may still be with us, but in the meantime, let me introduce our second speaker, Dr. Abdulrahman Alshamy. He is a consultant neuroradiologist and a neurointerventional radiologist at King Abdulaziz Medical Center. Medical City, the Ministry of National Guard Health Affairs in Jeddah, Saudi Arabia. He was also the former chairman of Medical Imaging Department at King Abdulaziz Medical City, Head and Exam Committee in Radiology Fellowship, Saudi Commission for Health Specialities, Kingdom of Saudi Arabia. He's having more than 35 years of experience and was an invited speaker and chairman of numerous conferences and seminars. Dr. Alshamy has done many publications and shared a number of clinical researches. Today, he will join us to speak about endovascular treatment for the chronic subdural hematoma. Dr. Abdulrahman, the mic is yours.
Thank you for the nice introduction. I hope the sound is clear. Just share the screen. Do you see my screen?
Yep.
Yes, doctor.
Okay.
We can see
Yes,
that.
we can see it.
Okay, great. Thank you again for this nice invitation, and I'm happy to introduce a little bit different topic. It's related to chronic subdural hematoma. And this is like a new intervention in neuroradiology field. Now we have seen a big evolution in the stroke treatment, and with the population getting older, we have this chronic subdural hematoma that is actually getting more and more common, and we see it more. So I'll just go through a small introduction and the rationale of endovascular treatment of chronic subdural hematoma with embolization of the middle meningeal artery. I'll show a few cases, and we don't have that big experience, but then we'll see the literature. So definition, of course, we'll go through the definition for this subdural hematoma. We'll see the problem of the aging population, problem of anticoagulation, and this disease, which is actually not really benign. So the subdural hematoma, I think it says by name, it's in the subdural space. So, and it's mainly venous, actually, it's not arterial, and this is related to minor traumas and affecting bridging vein that is ruptured, and then you have accumulation of blood in the subdural space, as the figure that you see in your left side. Now you can imagine if with the aging population, the subarachnoid space is getting bigger, then the bridging vein exposure in the subdural space become larger, and minor traumas that can affect the subdural hematoma is actually stronger. So why then when we have a subdural hematoma, how does it go into chronic? Why does it go into chronic? This is the issue, and there is only hypothesis, and this is nice schematic drawing that I've seen, and it's just giving the behind it what's the pathophysiology. So once you have a subdural hematoma, the theory behind it is that you have a cascade of inflammatory reaction, and within this cascade of inflammatory reaction, you have increased celularities that follows, you have growth factors, and then you have neoangiogenesis. And in addition to this, you have fibrinolytic reaction that keeps the blood a little bit fluid, it prevents a little bit coagulation. So this is the theory behind it. But again, so you can imagine that if you have neoangiogenesis inside the cellularity, which is you have new membranes within the subdural space, these neoangiogenesis. These are vessels coming actually from the middle meningeal artery branches. And we see this actually when we do the chronic subdural, when you do embolization in chronic subdural hematoma. This is the middle meningeal artery. You can see these cut in appearance, enhancement within the subdural space. This is a patient with chronic subdural hematoma, and this is what we think that is happening, neoangiogenesis, and these are the new membranes that are getting actually the supply from the middle meningeal artery. So it's true that the origin of the problem is venous, but with certain patients, they develop this chronicity and they have this neoangiogenesis, which is mainly supplied from small branches from the middle meningeal artery. And these branches, our new capillaries that's happening inside the membranes of the subdural hematoma, they have shown it in certain experimental studies that the gaps between the cellular membranes is larger, and there is leakage. Actually, it's like an exudate rather than true bleeding. So it's like exuda of plasma, maybe some RBCs as well, but it's an inflammatory process that continues and continue cascade. So now the problem with the population, I think it's increasing. The aging of the population is getting older and older. And even in the Gulf, I've seen this index in Saudi Arabia, index population, and we can see how we are getting to exponential phase here. So I think in the Gulf, although that we say that we have young population, but we are passing now into a curve and we're getting rapid increase of the population. The population, of course, in the Western countries, they have more this problem. I mean, we see this in the stroke, we see this in the chronic subdural hematoma, but I think we are joining them in the near future. A nice study here, it's done in a publication here, done incidence of chronic subdural hematoma from 1990 to 2015 in Finland, just to see what's happening with the incidence. So they had an overall incidence of chronic subdural hematoma that doubled actually from 1990 to 2015. So they had it in 8.2 per 100,000 per year to 17.6. So, and these are figures, we can find it much, much higher in North America. It reaches up to 80 in certain states in US. So it's definitely increasing. And the problem is that with this aging population, more and more we see patients getting anticoagulation and antiplatelet therapy. So as well, they have, for example, they have 30% of their patients were on warfarin, and 25 were in antiplatelet therapy compared to 7.5 and 25% in the beginning in 1990. So we have this combined problem of aging population and the use of anticoagulation and antiplatelet therapy. This chronic subdural hematoma is not a benign disease, and this is just a review 2011. Just seeing the morbidity and mortality they have here in Pennsylvania. They reviewed patients, 200 cases, 209 of chronic subdural hematoma from 2000 to 2008. So 137 patients had surgeries, 72 probably they were stable observation, but we have 16.7% mortality. And 130 that were discharged, they were discharged to a rehab or skilled care facility. So we can see that it's really a serious disease. And this chronic subdural hematoma, we need to find a better treatment plan. Of course, still the reference is still surgery. I'm presenting the endovascular and the neurointervention point of view. But of course, the reference, of course, still surgical and evacuation of the hematoma, especially when you have a midline shift, a certain percentage of accumulation blood, more than 1 centimeter. So the surgery is the first line of treatment. But when it shifts to chronic subdural hematoma, I think probably endovascular management can help. This is a review, a meta-analysis of 34,000 and more, 50 studies and 16 trials, just to show the morbidity and mortality. You're talking about mortality around 15%. And of course, there is good cure, around 80–85%. But we can see that this is a serious disease. So this is a nice study showing the role of anticoagulation, antithrombotic, and it's actually, we have different views in the literature. It's not very clear of the role of anticoagulation, of antithrombotic. I think we all agree that it is having a bad effect when you have acute. A is for acute subdural hematoma, and we can see that the recurrence and mortality were associated with anticoagulant therapy and with platelet aggregation inhibitors. So it does affect the acute phase, acute subdural hematoma, this anticoagulation, antiplatelet. But in this study, they did not find a difference actually in the chronic subdural hematoma. I really don't know, but I mean, it's just, is it really not affecting the chronic subdural hematoma? But strangely enough, they had higher, they have a little bit higher recurrence rate than the other meta-analysis that we have seen here, recurrence 24%, which is really, really high. So anyway, I'll show a few cases and we'll see other points in the literature. This is a patient, 76, diabetic, cardiomyopathy, of course, with antiplatelet therapy. And he had a fall and developed a subdural hematoma. Then he went for surgery, 2nd of March, 2021, Boehringer surgery evacuation. So this is on the left side, in the upper row, sorry, in the upper row, you can see the 1st of March, the chronic subdural hematoma. And with the anticoagulation, we can see sometimes layering fluid level of blood and the plasma, and you can see the mass effect. And this is after surgery with the drainage. So the burr hole and evacuation of the hematoma, this is 4th of March. But the patient was readmitted again, 23rd of March, weakness on the left, upper and lower limbs for 2 days and headaches. So again, he had, now we can see some loculations inside. You can see that it's not smooth and you have loculations. So we have an acute on top of chronic subdural hematoma. So this patient, this is the angiogram. This is the middle meningeal, the external carotid artery injection. And this is the middle meningeal. So the first slide that we have seen is a reflection of this patient. And this is the enhancement that we can see, the cotton appearance, fluffy, ill-defined, of probably some membranes within the subdural hematoma. And we just go inside and we embolize. Now, different way of embolization, we're not going to discuss a lot, but we have different embolic material. We can use liquid, we can use particles, PVAs, we can use coils, but the coils are not very effective. The idea is to have the embolic material going a little bit distal, actually. So this is onyx material, liquid, and this is after embolization. Now, this patient was admitted, we said, for recurrence on the 23rd of March. 4 days after the power improving, he was able to walk. And 14th of April, patient came to the outpatient clinic. There is no neurological deficit. And this is the CT scan, the 8th of June, the subdural hematoma almost completely gone. We can see just a little bit of trace of the membrane, which is thick. And this is the embolic material that you can see here within the middle meningeal artery branches. Now, there are certain considerations related to the middle meningeal artery because you know that there are always anastomosis with the internal carotid or certain supply to cranial nerves. But the main two concerns, most important, is anterior communication that we can see. If you can see branches of the middle meningeal artery going anteriorly into the orbit, then you have communication with the meningolacrimal branch, or you can have meningo-ophthalmic, so it can give supply to the ophthalmic artery directly. The other thing is just above the foramen spinosum, you have a petrous branch here, and this petrous branch is giving supply to the 7th cranial nerve, so you can have facial cranial nerve paralysis. So these are the two things that we have to keep in mind, the most dangerous parts, that we have to go avoiding the petrous branch, so we have to go higher. And the anterior branch, we have also to avoid it. Or we can go inside and put a coil and completely isolate it from the middle meningeal artery, and we can embolize the distal branches, avoiding particles or liquid embolic going anteriorly into the towards the orbit. Example is just showing strange communications. So for example, you can have variation. This is the middle meningeal artery arising directly from the basilar. So you can see it here. And this is giving both the frontal and the parieto-occipital branch. So there are different variations. This is a variation. You can see different branches here, the frontal and the posterior. It's coming from the ophthalmic artery. This is another patient. We have middle meningeal artery, but it's giving one branch here. The other branch that you see posteriorly, it's very large, and it's coming from the ophthalmic, the parieto-occipital, and it's is associated with the dural fistula. So we can have a lot of variations where we have to be aware. Whenever we do this, we have to do the common carotid and see the internal carotid, that there is an ophthalmic artery. Of course, when we do this, always we do a CTA before to have an idea of the aortic arch, because these are elderly populations. They can have atheroma, stenosis, to check the middle meningeal artery that it's present, the ophthalmic artery is coming from the internal carotid or not. The first case of chronic subdural hematoma embolization was published in 1994, and that was related actually for a patient with arteriovenous fistula. So it was a combination treatment of the chronic subdural hematoma and embolization of this fistula at the same time. So this is started the idea of having embolization of the chronic subdural hematoma, but there were only scattered articles, a few cases. The largest published case that it was like a big blockbuster, and in our field of intervention neuro, it was published in 2018 by Ban and his collaborators in South Korea. And they have a big series of 72 patients embolization for chronic subdural hematoma. And the results that they have the conventional treatment, surgery, or observation if there was no midline shift, nothing. And they're comparing the treatment failure. There's only one case of failure in the embolization group, which is 1.4%. And there is only this patient who had a surgical rescue. So a very small percentage. And we can see in the conventional group, the treatment failure, 27%, and surgical rescue, they have to go back again, 18%. So after this, several publications happened in Europe and Germany, and North America, showing similar results. But we still don't know which patient really will have more benefit. Is there a difference in certain patients or others? We don't know this, and we will see that there are a lot of trials happening. This is a paper, a nice review, 2020 in ACTA Neurosurgical by Haldrop, embolization of middle meningeal artery patients with chronic subdural hematoma. And this is a systematic review and meta-analysis. They reviewed 18 papers with 191 primary and recurrent chronic subdural hematoma. And the recurrent rate for chronic subdural hematoma embolization was 2.4%. And the primary, that means that when they see the patient for the first time with no bare hole surgery, they do embolization, the recurrence was 4.1%. It's still a much lower rate than surgical evacuation, but of course we cannot do this unless the patient does not require surgery. This is showing from this publication what was used, just to show you the different material. And the first material, the most common that people are using for embolization are particles. Then we can see the particles are PVAs. You can see a lot of particles. Some of them they did not mention what was clearly which material they used. The liquid embolic, which is here, they used glue. Few articles, but the majority that we have very large experience in intervention, particles, but now, of course, the liquid embolic, we have more and more experience in it, especially with AVMs. But this is the primary, is the particles that everybody seems to use and safe. This is another paper from neurosurgery, middle meningeal artery embolization for chronic subdural hematoma, multi-center experience, 154 consecutive embolization. And it's just to show that there was no difference. They used different material. They used liquid, they used PVAs. You can see here, the major part you can see is particles, and the liquid embolic is a small part of this experience. So the majority, they still use particles. This is a patient 84, diabetic, hypertension, ischemic heart disease, bronchial asthma with situs inversus, Parkinson, recurrent chronic subdural, and he was admitted 16 November with left temporal bone, pain. And then he came on 10th of December and they see CT, and he had a chronic subdural hematoma with increasing headache and eye pain, left deep facial pain, worsening rigidity, his Parkinson getting worse with gait disturbance. And sorry. Okay. You can see here, this is the 10th of December, the chronic subdural hematoma with layering, fluid level. And this is, the embolization was done in the 5th of January. And this is the 31st of January. It's getting less actually, but there is still some residual. And the 21st of June, it's completely gone. So the patient improved significantly, the headache improved, and he started to ambulating very shortly after embolization, within less than 10 days, started to ambulate, no headache. And when he came later to the outpatient clinic, he completely recovered. Another patient, 73, post-CABG, bladder cancer, he came to the ER 25th of October, left side weakness, mild headache. And he had embolization on the 30th of October, 2022. And the 31st of October, the left side weakness improved. So we're talking about less than a week. And another 2 weeks, total 3 weeks, no headache and no weakness. And this is 15th of October when he came. And we can see the loculation within the chronic subdural hematoma. And 13 November, we can still see a residual, but there is significant clinical improvement. So the imaging does not always reflect the clinical, and the resolution of the chronic subdural hematoma takes actually longer time, few months actually. And this is another similar appearance. You can see the fluffy appearance of the middle meningeal artery enhancement, and we're presuming that this is related to enhancement of the membranes with the chronic subdural hematoma. Another patient, 80 years, again, he had a bladder, this is another patient, diabetic, hypertensive, another bladder cancer, and he has weakness on the left lower limb. On the left side, 4/5, sensation was intact. He had evacuation the 3rd of October, so he had burr hole and drainage, and recurrent chronic subdural hematomas less than 3 weeks. So he was admitted again for embolization. This is 2nd of October, 6th of October after surgery, and 27 recurrence. And this is after embolization. The patient disappeared. So, and he came back only much later. And this is, I only could find this image from a PET CT. So you can see the resolution is very bad in the brain. But you can see that the ventricles are becoming symmetric actually here. So if I summarize, we have a problem of aging population. We have an increasing incidence. This is a serious disease. This population, they have comorbidities. Some of them, they have the dual antiplatelets, and it's sometimes we cannot stop them, or there will be consequences. Sometimes we have to do surgery if it can be an issue. The middle meningeal artery embolization is effective. We have to be aware of the dangerous anastomosis. We have different embolic material. For the time being, we don't know which is more effective than the other, but we have a good experience with particles. The cases that I've shown you, I think we have 4 of them with liquid embolic. I have 1 with particles. A lot of ongoing trials. I just took this from the website clinicaltrials.gov. You can see 16 ongoing trials all over the world. We are trying to see how we can select better the patients, which type of material is better. Is it liquid? Is it particles? We want to avoid complications, of course. Yeah, so these are the issues that we have. Don't forget, of course, I'm talking about from neurointervention point of view, still the first line of chronic subdural hematoma. When it happens, let's say the subdural hematoma is surgical, and surgery is still the first line of treatment. But there are certain trials when it becomes chronic, they do the embolization and they send the patient for surgery afterwards, so that the patient will have the benefit of both. So this is, I think, that I wanted to share with you. It's a new field, and I think the incidence of this entity is increasing with time. I think we should be aware about it, and it's a serious disease. Thank you very much. I'll stop sharing.
Thank you, Professor Abdulrahman. What a great presentation. Thanks for, I will ask both speakers and the co-chair, Dr. Athari, to join us. Yes, I'm waiting for, yes, Professor.
I'm here. I was answering some questions in the chat.
I can see this. You are so active. But sorry about that, but we will repeat the same questions again for
no problem. No problem.
So nice presentation by Professor Carlos, where he went through the challenge points that always, as a neurologist and stroke specialist, I will be asked by our colleagues or the junior people. Do we treat minor stroke? Do we treat TIA? How about large stroke intervention? How about the TNK? Many people are interested in that, and we can see this through the questions. Professor Abdulrahman, it's a new topic for me, and I believe Dr. Athari to approach the subdural hematoma through the neurointervention. It seems that the market for the neurointervention is growing, and you will notice that they are taking bit from here and there. So less clipping is happening nowadays, less carotid surgery is happening because the interventionist is more smart, and the technology is helping them. So yes, with no further delay, I will ask all our audience to send their questions on the Q&A bar. We will have the next 30 minutes to answer all your questions. We have a list of questions that I will ask my co-chair, Dr. Athari, to start asking, and I will have the questions for Professor Abdulrahman, so you can start asking the questions came to Dr. Carlos.
Well, he had a lot of topics that he covered, and these are all issues that he mentioned are always hot, and we don't have clear answers for all of them. One thing that is always an issue is these minor strokes. And when we see the patient for the first time, actually, we have to keep in mind that within the patient that we say minor stroke, we have mimics. Mm-hmm. So if there is no documentation, I mean, I think we have to separate the groups like we did. The big step in intervention is when we started using imaging. Mm-hmm. So I think for all patients, they should have a stroke protocol, whether it's minor or major. They should all have a CTA, and I do for all my patients with a perfusion study, because it makes a big difference if you're talking about there is a vessel occlusion or not, because now we're talking there is a vessel occlusion or not. Otherwise, we have a stroke clinical presentation, and we know that the mimics that can go up to 10%. I think it's difficult to treat patient with thrombolytics, knowing that we might have this number of mimics and there is a risk of hemorrhage in these patients. So I think, is it now confirmed that we have to do CTA for all patients?
Yeah, may I comment on that? So I think I agree. Actually, in our center, also CT and CTA is the standard of care for all stroke patients. I think important, and in some cases, especially for minor strokes, perfusion imaging may be helpful. But even those cases, remember that we have lacunar strokes, and they also benefit from thrombolysis. So some lacunar stroke cannot be captured by full imaging like CT, CTA, even perfusion. So that's why the problem with mimics. I don't think it's a problem, because even with in mimics, in patients with mimics, TPA is safe. It has been demonstrated in several large cohorts studies that these patients have not a higher risk of intracranial hemorrhage, those mimics. So that's why we need neurologists or stroke physicians just evaluating the patients properly, doing a good exam, talking to the patient, talking to the family rapidly, have a checklist, and then the patient has to be sent for imaging. But I agree. So CT, CTA should be the standard of care. It will be improve the selection. We will save time. It's just not even minutes between the CT and the CTA, and will help us to identify patients for endovascular treatment. Also, even patients with minor stroke may have a large vessel occlusion, and this is a real emergency. This is a problem. Then we start thinking of the CTA when the patient deteriorates. Did you perform the CTA? This is true, huh?
I totally agree. That's why I'm saying these are two different categories of patients. A minor stroke with large vessel occlusion is not like a lacunar lesion.
Yeah,
I think we should have different. There are different categories of patients. This is one big difference. If you have large vessel occlusion with minor stroke, you can have even large vessel occlusion with no symptoms. This is a problem.
Yeah,
it's acute, recovering.
Good collaterals.
Exactly. This is one problem. Second problem that I have is the NHS score. Is that not all, for example, NHS score 3 are the same. I can have an NHS score of 3, which is disabling the patient, and I have it in 3 that the patient can live his life. So why to take a risk with TPA with somebody who has normal life, he can do everything, or somebody who, for example, he's a surgeon and he needs all his skills, or let's say a driver and he has hemianopsia. It makes a difference for his life.
Absolutely. That is the definition of disabling stroke. Disabling stroke is the neurological deficit that in this particular patient may affect the quality of life and also the ability to return to work. For instance, a musician or a taxi driver is not the same a 90-year-old lady that has a mild paralysis. This is not worth it to be treated for. Of course, you just add on risk. So for sure, this is taking into account the definition of disabling, but also I think we need to refine how we measure disabling or not disabling, and taking decision based on that in a very individualized manner. But sometimes we don't have the time for this. We don't have even the family to confirm the quality of life of the determined patient. We have an 80-year-old patient showing up in the emergency room alone, and you have to take decisions. So that's why imaging is okay. Sometimes we treat patients that at the end of the day we realize the deficit was not disabling and the patient was treated. This happened to us because consider the quality of life of the patient. Maybe we can save TPA. But I think the most important thing to ensure safety of the treatment is the experience, the volume. If you have a established program with a consecutive patient with a checklist that you don't miss any point of the chain, because sometimes we are here in Europe, at least we are competing with our workflow. Our door to needle time has to be shorter than that 25 minutes, shorter than 20 minutes, but we miss sometimes some information because we are going so fast and we trying to take decisions without even talking to the family. And this is a problem even in my hospital. I always recommend my residents, please talk to the family, talk to the patient, just not go straight to the CT and treat the patient.
Professor Carlos, I will interrupt both of you here.
Yeah.
I give you 8 minutes to have a nice discussion between both of you, but we have almost 500 attendees and they have many questions.
No, please go ahead. Please go ahead.
So, Athari, you can start with the first question.
So it's just very interesting to hear two experts go through the whole discussion.
Nice.
I'll start with the first question for you, Dr. Molina. So even though TPA has not really received the full approval, is used in Australia, it is used like in certain places like Australia as the first line of thrombolysis in national system and even approved in India. Can it be used without worrying about legality?
Well, I don't know. There are different situations in different countries. So here it is not approved. There are some recommendations. I don't think there will be face legal problems. This is not the problem. It's not legal. The problem is the evidence that is built for TNK. I'm sure that in the future we will be able to build the solid evidence to recommend, okay, we can do the switch. I like the study from the Canadian group that they compare in a real open registry and compare it based on the registry, and they demonstrate non-inferiority of TNK versus TPA. This is the way to go. This is the way to build the evidence. But still, there are some uncertainties. For all stroke patients, is the same for all patients that for young patients, on all patients, they have a higher rate of hemorrhage with TNK. And also the dose of 0.25, it seems to be the safer and comparable to TPA, not the 0.4 that the NOTICE 2 was stopped due to hemorrhage. So we still need to know more. It's coming, for sure, it's coming, but I don't think it's a legal problem. It's more than, for instance, in Europe, it's not in the label for TPA. Stroke is not in the label. But still, some centers are using it. During the COVID, for instance, it was logistically easier to put a bolus. And if you ask the resident, they prefer in a randomized trial. We have a randomized trial now, TPA, TNK. They prefer TNK because it's easy, just a single bolus and go. And even for the drip and ship, this is really important. In the drip and ship scenario, you can shorten the door in, door out, and transfer the patient rapidly to the endovascular center. That's the main advantage, I think, is logistical advantage.
And the second question is, can you tell why tandem occlusion's best approach is to go directly for thrombectomy without TPA?
This is a really good one. This is a good one because it's, the issue is that if you decided to go for TPA and then the vascular treatment, think that in the case you decide to put the stent in, the patient has to be in dual antiplatelet therapy, increasing the risk of hemorrhage. So you have to take the decision beforehand. I tell you what we are doing in our center is that although, in a patient with tandem occlusion, so we treat the patient with TPA, we perform in those cases angioplasty, first an angioplasty, and then delay the final stenting for the 48 hours or 36 hours, and then we add also the antiplatelet therapy. Sometimes it's not that easy and straightforward, the decision. And in few cases, especially those at higher risk of hemorrhagic complications, even if they have a tandem, we go straight to mechanical thrombectomy, place on the stenting, and do antiplatelet.
So, Professor Molina, so you are stenting these patients on the same session, or next morning you will do that?
Yeah, in most cases, next morning we perform angioplasty, and then we delay the final stenting placement for the deployment for the next placement.
Okay, and usually we will keep them on Aggrastat or dual antiplatelet for the same period, which is 24 hours, then keep them for 3 months or 1 month on the dual antiplatelet?
Yeah, dual antiplatelet therapy, though high risk TIA minor stroke, they receive dual antiplatelet therapy, and those who receive a stenting for 3 months.
Okay. How about, because we had a recent challenge with this, one of the cases that our interventionist patients, no extracranial stenosis, but they're on the CT angio, question of distal ICA occlusion versus M1 tight stenosis intracranial versus thrombi there. So TPA was given, mechanical thrombectomy was done, it was a tight stenosis. So the question is, shall we stent it or not? So the team decided there, because patient had a poor collaterals, to stent that artery. So stented was done. Patients kept on agrastat that evening. Next morning, huge bleed.
Yeah.
So the question is,
it's a bad combination. TPA and dual antiplatelet therapy is a bad combination.
It's a bad combination. You agreed on that.
You have to dichotomize the decision, go or no go. If you go for TPA, forget the dual antiplatelet therapy for the next 24 hours. Excellent. This is the decisions. Yeah, the exception probably is the basilar artery occlusion. If you have a severe basilar artery occlusion, this is a different scenario, because the risk of reocclusion and complications is high. In those patients, if, for instance, it's a basilar artery occlusion patient is treated with TPA in other center, it's transferred to our center, so the patient's already treated. So we have to go for thrombectomy, and we perform the thrombectomy, but still we've seen a tiny plaque. So in some patients, we let an infusion of tirofiban, for instance, or put an stent in, and we take the risk because it's a basilar, proximal basilar. But for MCA, I think the approach is, as you mentioned, is better to skip multiplatelet therapy. Even in
Professor Abdulrahman, are you doing the same in Saudi Arabia?
Well, we don't have that much. I mean, it's the same problem. I mean, it's in theory, there is a difference, number one, for the tandem occlusion for the carotids. The carotids, I think the approach for me is a little different with dissection or atherosclerosis. Atherosclerosis, it's a chronic stenosis, so it's not something acute. So in these cases, not really in a hurry to put a stent for the carotid artery. So my main target will be intracranially, not carotids. For intracranially, I think it's a problem that we are all facing. I mean, there is no, if you want to do something, you don't have collaterals, you have to put a stent. There is no other way. The thing is that probably you have to do a Dyna CT or CT-like images, cone beam CT on the spot. And you have to evaluate how big is the infarction before you do this, because you want to have at least some benefit for the patient, at least on imaging, that there's no large infarction. Then in this case, yes, you put a coronary stent. I prefer, yes, coronary stent, very small, the smallest, shortest, and put a coronary stent there.
Okay.
It's a problem, yeah.
Agree. I have a question, Dr. Athari, for Dr. Abdulrahman from Muhammad Al Mirza. It's a question. Hi, Professor Abdulrahman. Thanks for a nice presentation. Do we get from your lecture that every patient with chronic or recurrent subdural hematoma, we have to suspect AV fistula and to treat them with the embolization? Is that correct? I'm not sure from where did he get the AVM.
Yeah. I did not. I think maybe he saw the case of variation of a fistula. I was not talking about the chronic subdural hematoma. I was just showing variation, anatomical variation, that we can have a branch coming from the ophthalmic in a patient who had a dural fistula. But no, the chronic subdural hematoma has nothing to do with AVMs or fistulas. It's, as I mentioned at the beginning, it's a theory that we're thinking within the subdural hematoma, there is a cascade of inflammatory reaction, and you have membranes within the subdural space. And these membranes are supplied by very small capillaries coming from the middle meningeal artery. So no, it's not related to any vascular malformation. But if chronic subdural hematoma, now there is a center in France, they treat them all when it's chronic. They treat them, they embolize them all, and they send the patient for surgery. So before they go to surgery, they do the embolization to get the benefit of both.
Interesting. So that was a second question. When do you make the decision for embolization for these subdural hematoma? Is it during their acute phase, subacute phase, or the chronic one? And you answered this partially now.
Yes, we're talking about chronic. We know the acute is surgical. Acute subdural hematoma, this is surgical treatment, and this is the first line of therapy. I think I was talking about only chronic.
Okay.
Acute is surgical.
Okay.
Abdulrahman, if I may add to this, do we still, like for the chronic ones, like when you do the embolization, use the same threshold as the surgery one? Like usually we read like if there's a midline shift or like the size of the chronic subdural, or because like it's an easier procedure, like size doesn't matter as much.
It's not that simple procedure, you know. They saw in the literature of the meta-analysis the average age of these patients compared to the stroke patients, and the population in the chronic subdural hematoma are older than the population of stroke. And these are comorbid patients. They have very ugly vessels, very tortuous vessels. But definitely the risk is less than the stroke. We're not going intracranial. We have tortuous vessels, but there is a risk. But I forgot you were talking about if we do it for all patients or not. This is the question?
No, like usually when we say like the approach for the chronic subdurals, like they usually go for
you know, all these cases, the five cases that we have, these are failed surgeries. So the patients, they have a burr hole surgery, an evacuation, and it reaccumulated.
Okay.
So we're gaining experience, but now other people are doing it routinely before surgery. They embolize and they send the patient for evacuation.
Nice.
Interesting. I will ask our speakers because time is running and we have many questions to answer, and I don't want you to stay later to answer them on Zoom. So, Athari, you have many questions for Professor Molina?
For Professor Molina, one of the questions here, like because now that we know that do we have a good insight for TNK being used as an optimal substitute for TPA for the future now with the meta-analysis presentation that is non-inferior TPA? And that so, is there a limit usage of TNK according to an NIHSS score similar to what we use with TPA?
Yeah, I think it's going to be the same. Just going straight forward, it's going to be the same. So the same limitations, same indications. Actually, the trials performing by trying to demonstrate non-inferiority are designed the same that the former trials of TPA. So it's the same. Even for minor stroke, it's the same. But still, we need to categorize the what is the scenario of TNK in the future. But I expect it's going to be the same. And especially for door in, door out, for those patients that have pre-thrombectomy, it speed up the process.
Okay. One more question we have here. What's the cause of doing CTA for all patients in window, even those not candidate for TPA, like the TIA or the minor stroke?
For sure. You have the information right away. In my center, we perform duplex ultrasound in the ER 24/7, and still in this scenario is operator dependent. It's better CT, CTA. We perform CTA from the arch, from the aortic arch. So in some cases, we can even detect even if the patient has a TIA or a recurrent TIA, you have a carotid stenosis as a cause of TIA, or even an aortic arch thrombus. Yeah, for sure, CTA and CT. I agree that CT and CTA should be the standard of
care. Quick one, is a small chronic subdural hematoma a contraindication for TPA?
Yep, for sure.
Okay.
Old one, new one. Sorry. Old one and new one. Is it a small one, chronic subdural hematoma? Is that still you will?
For embolization, you mean?
Yes, for TPA.
For TPA is a contraindication.
Contraindication for TPA. Okay.
So send them for embolization.
No, embolization.
for embolization.
I will send that patients directly to mechanical thrombectomy if there's a proximal occlusion. There's a question, Athari, from Dr. Fatima Al-Kindi to Dr. Abdulrahman. If you read that question, Abdulrahman, 80 years old, patient with atrial fibrillation on apixaban, had subdural hematoma with midline shift and not candidate for operation due to comorbidity condition. Would you consider embolization in this lady? Second thing is, what is the largest period which MMA can be performed after 1 to 3 months from the onset? So 2 questions.
As I told you, I mean, it's any number one, if there is a failed surgery, definitely there's an indication. Now, for this patient that you're referring to with comorbid factors, apixaban and anticoagulation, yes, definitely we can do it. But the issue is that if there is a neurological status problem, if there is a midline shift and the patient is paralyzed, this is a surgical procedure. I mean, it's not, we can do the embolization, but as I told you, it will not change immediately. We can stop more accumulation of subdural hematoma and start to regress. So if the patient is tolerating, yes, we definitely can do it. We definitely can do it.
Okay, thank you. Athari, back to you.
Okay, another quick question for you, Dr. Carlos. Minor stroke with LVO, best approach now is TPA and not thrombectomy?
So,
is that the right time?
The patient is large vessel occlusion and minor stroke, so TPA for sure. The question is whether mechanical thrombectomy or not, and this is in their trials now. The MOSTER trial, the distal and the escape MEVO that are trying to solve it. It's not the escape MEVO is more for distals, but this trial will solve this problem. If you pass a proximal occlusion and non-disabling stroke, TPA is indicated. If the disabling stroke, disabling minor stroke and proximal occlusion, for sure, we go for endovascular treatment.
Can you just highlight on this one? If a patient is presented with a minor stroke, but there's a proximal occlusion, do you have a concern that overnight this patient can have a long, big stroke and a complete occlusion of that artery, and patients outside the window, TPA has been passed? So what you are doing in Barcelona usually, do you go for
straight for thrombectomy, with TPA and thrombectomy? We don't wait for clinical deterioration because we know this story. So some neurologists advocate also wait and see. So put the patient in the stroke unit and control blood pressure and let's see. And as you said, it's like you go out of the window, then no reason for TPA, no mechanical thrombectomy, nothing. So if you don't miss the opportunity, if you have the patient right away, treat it, because don't wait for clinical deterioration.
But Dr. Carlos, don't you check the size of the clot? Like usually for us, if the M1 occlusion is like almost like a very small clot that does not even look like it's fully there, that we know that TPA probably will be sufficient, and the patient had minor presentation, you would still try to take them for EBT?
But you never know. Huh? Even small clots, you see, oh, this is good for TPA, and you have. Yeah. Actually, we analyze the infrastructure, the structure of the clot obtained by thrombectomy, and some small size clots are fibrin rich, difficult to be lysed for TPA, not good for thrombectomy. And on the other hand, you can a relatively large clot. This is a red clot that can respond at least partially to TPA.
And Athari, it's very important. Also, if you thought that these are minor stroke, but there's a question of proximal occlusion or the flow, there's a partial stenosis there. To do a diagnostic for vessel, Dr. Abdulrahman, that's something very simple. If team is there doing the 4-vessel imaging, and then you can build your diagnosis, because it will be worthless that the patients will be admitted, the chance of doing any thrombectomy, next morning you are coming and patients having full M1, and unfortunately you didn't take the decision because it was a minor presentation. Abdulrahman?
Well, I think, I mean, number one is I have just a small comment concerning the TPA large vessel occlusion. I don't think the percentage to work here is, we know from the literature, it works only in around 15% or 20%. It's a small percentage. So large vessel occlusion, I think the role of TPA is limited. Now we want to do it as a routine, yes, it always helps, but I think thrombectomy is the first line. Now, we do have a medical-legal aspect of it, because still the indication is always talking about NIHS score, it should be 6, aspect score should be 6. So, you know, some patients, it can go to legal, it can go to justice. And why did you do thrombectomy for a patient who have an NIHS score of 3 or 4? Well, he had a large vessel occlusion. Well, this is not in our guidelines, not yet. We don't have any guidelines yet for minor strokes with large vessel occlusion. We don't know.
Yes, I will have a concern there. It's a patient's family discussion. That's number one. The consents will be taken there. From our experience in Dubai that we are practicing, also when a patient is presented with a minor stroke with hemiparesis right side, and he's improving. And we see this so frequent in valvular type of M1, where patients will have dense, then when you come at hand, but still there's this proximal occlusion. So we advise the patients and the family to go for diagnostic, and if we found that partial occlusion or complete occlusion, that thrombectomy or the suction will be done. Carlos.
Well, I think that still, as I'm showing my slides, so in general, the combination, the mechanical thrombectomy alone cannot replace now to bridging. In general, even in patients with the large vessel occlusion, even if they have minor symptoms. I agree that the TPA alone accounts for the low rate of recanalization patients with large vessel occlusion, especially M1 and T occlusion. So you know that the response will be very limited, if any. But still, sometimes you have situations in real life that you have difficult access with the catheter is difficult. This happens in real life, especially in old patients with have some tortuous aortic arch. It's difficult to get to the clot, but it takes time, and you delay the initiation. You start thinking, where is the TPA? But still, this is true that still we use bridging in all patients. There are some exceptions. If you have low aspects, high risk of hemorrhage, dual antiplatelet therapy, and an old lady that is close to the window is 4 hours, and so better skip TPA in this situation, of course, and go straight to thrombectomy. Even we have in our institution, we have a protocol of direct transfer to the angio suite. So patient transfer, the ambulance transfer the patient to the angio suite before dynasty, combined CT, and go. It's like this. If the pre-notification is pretty clear, we don't waste our time and we go for thrombectomy. This is the exceptions that in some of those cases we skip TPA because we are so clear. It's so clear that it's there. But in the rest of patients, so we perform TPA, we give TPA and the mechanical thrombectomy.
And also, I would like to add, sorry, Athari, about this. It's infrequent, but we will see it once a month that patients coming with a proximal occlusion, very clear hyperdense sign, TPA started, call the interventionist. When they will go in, they will say, oh, Suhail, it's gone, it's not there, TPA work, okay? So, and that's, I will say it's infrequent, but it's happening 1 out of
10%.
Yeah, of these cases coming within the window that they will get this nice result. So still TPA is always there. As Professor Molina said, it's if my cath lab is ready, everyone is there. We just a couple of weeks back, patients came with TPA, proximal occlusion, M1, went for TPA thrombectomy. Team was there, and we have 2 angio suite. Another patients came at the same time, and the room is running, and our interventionist, 3 of them is there. Patients went directly to the thrombectomy, bypass TPA, but that's unusual. It's not always the case. We'll go back to the questions, Athari.
Because we're still on the same topic. So how about if your patient comes in with TIA and LVO? Would you still go for EVT?
TPA and EVT.
TIA?
TIA, not TIA. Yeah.
And he had large vessel occlusion.
Like
becoming trickier more and more.
So
TIA.
Yeah. Well, you have to, it's not whether you have symptoms or not. I think it's at the NIH, I'm a neurologist, but the TIA sometimes is overrated. So if you have the occlusion, what is the difference between an AH of 2 or 0? Probably the time of evaluation, probably 0 now, 2 in 1 hour. We go for it.
I will have 2 comments there, Athari. I don't believe a TIA coming with a proximal occlusion is true. So I will send patients for MRI, MRA, and we will do the diffusion study as Professor Abdulrahman Alshamy mentioned. So that's need to be done because there should be something. Second thing, it could be a very tight stenosis and they label it as an acute occlusion, and most likely that will be the case in this patient's chronic stenosis and presentation with the TIM. Prof. Abdulrahman, anything you would like to add in this case scenario?
No, I think just to add is that the material we're using is evolving, and we are becoming more and more enthusiastic to go in, actually. I remember in the beginning, we are a little bit hesitant when you see that you have minor stroke. Shall we go or not go? No, we'll wait till the patient's okay. Now the material is becoming softer. They are larger for aspiration. We have different stents. We can go even with smaller stents into the M2, M3. There are different materials, and it's now having very, very large bore aspiration catheters coming. We don't see them here yet, but they are in US and they're coming soon to Europe. And I think they will come soon. So I think the good thing about the interventional part is that the technology is in our favor. And I think we are having new material coming. Probably new stents will come intracranially. We don't have perfect stents yet intracranially. We don't have them, not good ones. But I think this will evolve. Definitely, it's an area is evolving.
And actually, also, let me add something. So I think the mindset of neurologists is also evolving, and we are more proactive to just don't wait for the things to happen. Just act now. You are in the window, and the sooner the better. So treat the patient. Don't wait for clinical deterioration, even for minor strokes. So, and if you have experience with TPA, and I remember in the early 2000s when we published some papers about hemorrhagic transformation. Everybody was concerned about hemorrhagic transformation. And this is not the case now. Now we are not talking that much about hemorrhagic transformation. We're more talking about clinical outcomes and how to improve outcomes. And we demonstrate that the more the experience, the center in volume on treating patients with both TPA and mechanical thrombectomy, the better the results. So this is the learning curve. So we experienced the last 2 decades a very rapid learning curve. That's why I think we need to be more proactive, rely on actual the current imaging modalities that are available, CT, CTA, rapidly stratify the risk of the patient for clinical deterioration or not, of the possibility of good outcome with different treatments, TPA or mechanical thrombectomy.
Right. An easy question here for you, Dr. Carlos. Is there any restriction for mechanical thrombectomy for a patient who was treated previously with mechanical thrombectomy in a case if he had another stroke?
No. So, you know, we have patients with 2 or 3 thrombectomies with the malignant.
Yeah. Now it's strangely enough. I mean, I remember in the old days putting a stent in the inside intracranially to say that you should not move the stent. And now we're putting the stents and we're dragging down. Yeah.
It's another interesting question from Dr. Diana Khadr. How do we differentiate between old stenosis and acute occlusion before thrombectomy?
That's a good one. I think it's really difficult. I look at imaging usually. I try to see the C- as well to see if I have calcifications inside the M1. I can try to see the morphology of the contrast that it stops in the MCA, if it's tapering or is it a direct stop, like just a block. So these are semiology, it's not really, we don't have any sure answer. We're developing now new wires that they ultrasound maybe or analysis to see if what's the occlusion, is it to analyze it, but we're not yet there. I think it's really difficult. It's just morphology and semiology to see the type of occlusion, how is it, and how is the vessel, if there's any calcifications or not.
Do you have more tricks?
MRI, some people, they work in MR, the T2 gradient, if they have a good blooming artifact in the T2 gradient, they think it's a red clot. I don't have that much experience in MR for acute stroke, but this is what I see very commonly. They say this is in favor of acute red RBC clot.
Is it fair to say we can never really be 100% sure without going for before the actual mechanical thrombectomy?
I think yes, we cannot. For the time being, it's probably coming. They're developing new material. I know that there is in Australia, they're developing a new guide wire to analyze what type of clots. But for the time being, no, we don't have it. We don't have this.
Yeah, we are analyzing the clots once they are extracted, but there is no point of care like this to take decisions or more passes based on the clot structure. There's companies sensor. They have like, you know, they are familiar with this for sure. But it still is not that accurate that you can predict the outcome of how many passes you need to do.
Thank you. Yes, Athari, I think we reached 90 minutes. Time is running very quickly between Barcelona and Riyadh. Is that Dr. Shami?
In Jeddah. I'm in Jeddah.
Okay. So
Jeddah.
It's amazing how this webinar, we have Professor Molina, someone from Kuwait, someone from Dubai, Jeddah, and Barcelona. 90 minutes is finished and the question is still coming. We have a wonderful number of attendees across the Middle East, and it seems that we have some people from Australia and India. At the end, I would like to thank our two distinguished speakers tonight, Dr. Abdulrahman Alshamy from Jeddah, senior radiologist, neuroradiologist, and neurointerventionist, and also Professor Carlos Molina from Barcelona, head of neurology section and stroke unit at Vall d'Hebron Hospital in Barcelona. Also, I would like to thank my co-chair, Dr. Athari Salmeen, head of stroke chapter in Kuwait, and nice to see you always, Athari. At the end, this webinar will be on our YouTube channel for MENA Stroke Organization, and you will get all the audience, your CME hours within 2 weeks from today. I would like to thank our supporter, Medtronic and Boehringer Ingelheim, for their support for this type of educational webinars for the last 12 months. Today was number 12 for this year's of MENA Stroke Grand Round 2022. We will see you next year in January with a new program, with the new speakers, but it was nice to finish this webinar with France and Argentina, I mean Barcelona.
There's plenty of Argentinians, so it's like a party here.
Thank you all. Thank you. It was really...
Who's Barcelona, who's Argentina and France here. Dr. Abdulrahman, you would like to add something?
I just wanted to thank you for the nice invitation and for joining and discussing. Really very enriching experience. Thank you.
Thank you. Prof. Molina?
From my side also, thank you very much for the invitation. I enjoy a lot. I can do this for hours. Just 1.5 hours. I enjoy a lot of the discussion. I learned about this embolization and the endovascular treatment for subdural hematoma. Very interested in it. So very nice discussion.
Thank you, Athari. Thank you again. Have a nice, wonderful night. Thank you, Akilash, for being with us. Thanks for